This video is an instructional video designed to assist students in the proper technique and skills with regard to inserting central lines. We're here in the operating room right now. We have a mannequin, and in nurse anesthesia practice, many of the central lines are inserted in the operating room. Some are inserted on the floor outside the operating room, but I think the majority of them are probably inserted in the operating room. And that yields a great advantage because you've got folks that are asleep on the table and motionless due to the anesthetic, and you can put them in the proper position and identify landmarks a lot easier potentially than you could if a patient was moving and uncooperative and worried about being stuck and that sort of thing. When you're getting prepared and getting set up for central line insertion, you're going to need a flat surface that doesn't move, and there are a number of items in the operating room that can help you out with this. We've got this right here as one item. You'll see a lot of these in the operating room, lots of different colors, lots of different bags attached. This is what either linen or trash gets thrown in. I don't necessarily recommend that, but if that's all you have, it's utilized a great deal in the operating room. Here is a little cart that's got a flat surface. It's used a lot of times to unfold your kit and your tray and your gloves and your gown and that sort of thing. You actually have a mayo here. Sometimes those mayos are available and you can use it. You see here's the old familiar anesthesia cart. Folks will use this also. It's not the greatest flat surface to use because you've got the little pockets here up above that your syringes and that sort of thing and supplies are stored in, so you're not able to actually unwrap your kit fully, and you do risk contamination. That can be also said of your anesthesia machine, which is a flat surface. You almost need a flat surface that has no walls on the back, like a Mayo or any of these other three. I've brought a few kits in here just to show you the different manufacturers. Most all of these kits have the same pieces in them. They may look a little different. There may be some things in one kit that's not in the other. But and some kits, of course, do cost more. A lot of times it's cost that drives whether a kit is used or purchased by your hospital. One of the main things, though, I did want to point out is some manufacturers will list the centimeters. And I know this is important because depending on what site, whether you use a subclavian, the right or left, or the right or left IJ, or wherever you place this catheter, you're going to need to know the distance from the insertion site to the junction of the superior vena cava and the right atrium. And you see here on the bottom, this is a 20 centimeter length catheter, which is very common. That would be ideal if you were putting it in the left IJ. We know 15 centimeters would be ideal if you're putting it in the right IJ. This particular catheter says 8 inches, but it also says it's a 20 centimeter. I also have another catheter here that says it's a 16 centimeter, would be ideal for the right IJ. So there's a variety of kits. I also want to point out some of these kits give you additional supplies, and this is actually what we call the super kit. It's got a lot of great supplies. It's got a very nice guide wire that is a little bit better than the other guide wires. It's less flimsy. It's able to be maneuvered a little bit easier, and it has graduated markings on it that allow you to see the 5 centimeter, the 10 centimeter, and the 15 centimeter point of where the guide wire is. Well, let's take a look at gowns. We know that the standard of care when putting in a central line, regardless of whether you're putting it in the operating room or in a remote area such as the emergency room, critical care unit, that sort of thing, you need to have a gown, a glove, mask, hat. And you may not always have the luxury of having someone unfold the gown for you and give it to you. But that's okay. It's easy to put on a gown, and I'm going to show you how. But let's unwrap this. If you were to take this out of a package, it would be sterile. But in this particular instant, it's not sterile. It doesn't need to be sterile right now. The gown is sterile on one side, but the side you're going to grab is the non-sterile side. It's wrapped in this very thin wrapping here. And if you happen to have wet, if you could wrap it before you wash your hands, if you happen to have wet hands when you're coming in here after you've scrubbed, which may or may not be the case, they have a little towel here that you can dry your hands off with. You don't have to have that. But let's take a look at this gown. I'm grabbing this gown with my bare hands, which is what you want to do. And this gown is folded in such a way where the inside is toward you. And there's a little pocket right there and a pocket right there. And that allows me to grab inside here, open it up, shake it, and the gown will unfold. And when it unfolds, the inside of the gown is toward me, and the outside of the gown, of course, is on the outside. And I'll show you in a minute how to actually put this on. Okay, the proper way to put on this gown is we can grab it, and you see I have my hands in the slots. We talked about this. Have my hands in the slots. I can grab it here, and then I can shake it. Now the inside opens up toward me, the outside opens up. You can actually use your hand and grab it, and then you're able to do this. All right. Now I've got my gown on, and I can actually have either someone tie it for me, or what many folks do is they will actually grab it and tie it themselves. I remain sterile, and I have not touched any of the sterile part in front. Now I can actually don my gloves. All right, there's my gloves. Okay. Now I'm gowned and gloved. Let's assume I have a hat on and a mask on. And I'm ready now to do my central line. Well, let's take a look at this kit, what's inside of it. We have an arrow kit here. I'm going to peel off that, peel this back, and you want to open away from you. What we have in this kit is a number of things. One of them being, this is what we're going to wipe the skin off with. We've got a very exceptional drape right here. This drape's got an actual backing. It tells you right there what the head is. You're going to be able to put it down on the patient and then be able to unwrap it. I'll show you this in a minute. We've also got a couple of gauze pads that allow us to dab blood once any bleeding may be occurring during the insertion. Here we've got a guide wire. And this guide wire, I don't know if the video will show this, but it's nice because I think it does. It's got a mark right there for 5, another mark which is 2 marks for 10, and then we've got 3 marks, and that's 15 centimeters. So you will know when you're at the 15 centimeter mark. We've also got a 5cc syringe and a 22 gauge seeker needle. This is what we're going to use to seek the vessel, locate the vessel. We also have a small 3cc syringe with a small needle, 22 gauge, and it's a shorter needle, and that is for putting in local. We've got a little local here. And what I'm going to tell you about the local is this. You can certainly use local, but you don't necessarily have to if you're in the operating room and your patient is already asleep and anesthetized. Local is not necessary. We also have, in this particular kit, which is the super kit, we have the actual 18 gauge needle here. And this is a big barrel needle. It allows for the guide wire to go through it. And you see here we have a hole. You could actually put the guide wire right through here. It could go all the way through the barrel, because in the center there the barrel comes through, and you would never have to actually disconnect the syringe from the needle. The reason we don't seek with this big 18 gauge, if we're doing an IJ and we're seeking around with this, we could inadvertently puncture the carotid artery, and that would be a very bad thing with this needle. It's a bad thing anyway, but it's a bad thing with a big 18 gauge needle as opposed to the smaller seeker needle. We've got a little suture here with a straight needle. This allows us to tie it in. We've also got a little razor here. This allows us to not only cut the suture, but it allows us to puncture the skin before we put the dilator in, the vessel dilator. Here is the vessel dilator. Here is our catheter. And what happens is the catheter comes typically with the cap screwed on. You see, I've already removed in this cap. I've used this kit before. Here's the distal cap. We've got a distal port, a proximal port, and a medial port here. And they're all labeled. And the biggest port, of course, is the 16 distal. That's where your guide wire will be coming back. You've got a medial port, which is an 18, and a proximal port, which is an 18. We also have some writing on this catheter. This right here tells us that it's, and I don't know if this is a good shot here at all, but it tells us the 15 centimeter mark on this catheter and gives us some graduations down to 10 centimeters. When you end up threading this catheter in the patient over the guide wire is going to exit back out through the distal port. So you're going to need to have this already unscrewed. Just a few other things we have here. Since we're breaking a glass vial to withdraw local, to be, numb up the site, they give you a small little filter needle. You can use it if you want. Also, they give you an extra syringe, and they give you, this is an angiocath type situation here, where you could use the big needle or you could just use an angiocath. I choose not to use this, typically. You can place all sharps in this little red thing right here. Also, they give you this, and we'll show you this in a minute on the video, but this allows you to, if you have a longer than normal amount of catheter sticking out and you want to anchor it down, you don't want it just flopping out. Let's say you have a 20 centimeter catheter and you're putting it in the right IJ, that technically should be 5 centimeters hanging out of the patient's site of insertion. And if you want to tack it down, besides using this, you can use this and tack it down further down here, closer to the site. I want to take a second and show you this picture again. You've seen this picture. It was out of one of your textbooks. And it was also in the PowerPoint lecture. But you've got your landmarks, which are a triangle. You've got the base of the triangle being the clavicle. Then you have the sternal head and the clavicular head of the sternocleidomastoid muscle. And typically you go 3 finger breadths above the clavicle and you palpate the carotid artery, and then you move lateral, because the carotid artery is more medial and you're sticking the IJ, which is more of a lateral vessel. You're going at a 30-degree angle to the ipsilateral nipple. Okay, let's take a look at the 2 heads of the sternocleidomastoid. We've got the sternal head and the clavicular head, and then we've got the clavicle. This makes the base of the triangle. We'll go 3 finger breadths up, palpate the carotid, and this is where we'll stick. Some folks do draw a triangle, but this is a pretty clear landmark here. It's going to be easy for us. We'll be able to palpate the carotid, and I'm palpating this carotid. And if you go down here, I've got an ipsilateral nipple right over here. That will allow me to determine what proper angle I'm going. Okay, prior to me getting gowned and gloved up, you identify your landmarks, which we just did. You're going to open up yourself a prep. It could be this kind of prep, or it could be one of these preps where you just break it and it starts oozing out of the sponge. But at any rate, you're going to work yourself from the inside out. In this particular instance, they give you 2 or 3 of these betadine soap swabs, 3, and you're going to work yourself a nice little prep. Once you do that, then you can, while it's drying, you can go and open your gown and your gloves and put those on and get ready. As soon as they're dry, you can go and get your kit. Here we have a drape, and this drape tells us that the head is up. Got a nice little peel off back. I'm going to take this drape and I'm going to put it down right here, and I'm going to pull this off like this, move that like that, and then let's say, for instance, you put this down wrong and it's sticky. You can actually pull it up here and put it where you need to. So it's easily moved. Then I'm going to take this, unfold the rest of the drape here, and get this ready. Now I've got me a nice sterile surface. Now some folks will go ahead and pre-flush the catheter with saline before they put it in. You can do that if you want. You don't necessarily have to. Just make sure that each lumen of your catheter is clamped. And after you flush it, make sure that it's clamped and the cap is on tightly. You don't want air to be sucked in. Also, as soon as you do puncture the vessel and get the guide wire in, you don't have to leave the patient in Trendelenburg. You can put them flat. Okay, now we're gloved, gowned, prepped, draped. We're ready to stick. We know where our landmarks are. I'm going to take my seeker needle, have my bevel up, and I'm going to hold it like this. And this allows me to pull back as I'm searching, so that I have a little negative pressure when I do puncture the vessel. Blood will come back through the hub and into the barrel of the syringe, and that'll, of course, let me know that I've got I'm in the vessel. So I'm going to place my hand on the carotid artery and feel its pulsations. I'm going to go at a 30-degree angle, and I'm going to go toward the ipsilateral nipple. At this point, I'm going to hold my hand right here, and I've got the bigger needle. I have got the seeker needle and found the vessel. I'm going to go the exact same angle with the bigger needle as I'm pulling back, and once I go in there and get blood, which I have, I'm going to pull the seeker needle and its syringe out and place it over there on the tray. Now I've got blood. I'm in the vessel, and I've got the bigger needle. I can unscrew the syringe, and typically you're in Trendelenburg, mild Trendelenburg, with the head tilted at a 45 degree angle. So you're going to have some blood come back. If it's bright red, you know you've hit something probably wrong. If it's pulsating back, you know you probably hit something like the carotid. But I'm going to hold my finger over the hole of the hub so that I don't have blood spill back. Just a few things about this. If you've got a patient that is in Trendelenburg, if they're in enough Trendelenburg, then this vessel is actually, the IJ vessel is going to be below the heart. Very unlikely that you're going to have an entrainment of air pulled into the vascular system, central circulation. Also, if you've got an ET tube down this patient and they're getting positive pressure ventilation, you're going to have positive pressure in the interthoracic cavity rather than negative pressure. So what you're going to be doing is you're going to unscrew your syringe, and you're going to hold your thumb here because you don't want blood just bleeding back out. Some folks would say you're going to hold your thumb here because you don't want it to pull in air. Well, that's true, but it's going to be a little bit more unlikely if you got the patient in Trendelenburg and you're giving them a positive pressure ventilation. So you're going to hold your thumb over here to keep blood from backing, spilling all over the place. Now I've got my thumb on the hub. I'm going to get out my guide wire. And you see this guide wire, we talked about it. It usually has a cap on it. I'm going to pull the cap out. I can maneuver the guide wire on this little guide wire housing with my thumb. I'm going to come in here. And just for the sake of stopping at some point, I'm going to stop here where my two markings are, which indicates that I'm in 10 centimeters in. Of course, you would stop sooner if you looked for ectopy and saw that there were ventricular ectopy going on. So at this point, I'm going to pull this back, set my housing down. Now I'm going to pull my wire back. And if you need to, you may have blood oozing from this site. That's why they give you this. Here, I could tap blood that was oozing out. Now I've got me a guide wire. It's in the vessel, and I need to dilate the vessel. Before I dilate and push this big dilator through the skin, I'm going to put a little slice right there through the skin so that it doesn't rip and tear the skin. going to grab my dilator, thread this dilator through the guide wire, and I'm going to go 2 or 3 times down, 3/4 of the way or all the way to the hub, whichever. But don't force. Any of this stuff you do not force. Pull that out. Now I'm ready for my central line. And you can see here with my central line, I have the distal port cap off. And this is an important thing I want to talk to you about, because the distal port cap, if it was on, it would prevent my guide wire from exiting, and you could potentially, and it has been done before, push the guide wire all the way in and unable to retrieve it. I'm going to unclamp. Okay, now I'm going to push this through, and as I'm feeding my catheter through, you see I'm all the way in. I'm all the way to the site. If my guide wire has not exited out this hub of the distal port, I don't want to continue pulling. I want to come back here and pull a little bit more guide wire out. I don't want to push this catheter in past the site until I have gotten my guide wire where I can hold it here and keep it from being placed into the patient. At this point, I've now got a good grip on it, and I can advance my catheter all the way down to the 15 mark. Of course, if I do see ectopy when I'm advancing my catheter, then I know that I've gone too far and I can withdraw. All right. Once the catheter is in, now I can take my straight needle and my suture and sew it in. What I wanted to show you earlier was, let's say this is a situation where this is not a 15 centimeter catheter that I'm putting in the right IJ. This is a 20 centimeter catheter. At that point, I would stop about right here, and I'd have a lot of this hanging out. I can either loop this around and suture it in, or I can put this little piece that they gave me here that allows me to anchor it in closer to the site of where the catheter exits through the skin. And that keeps the catheter from pulling out. Once this catheter is in, you can use it, and once you get to the recovery room, then you can write orders for a chest x-ray. If you put this catheter in outside the operating room, you want to ask for a chest x-ray to confirm placement prior to you using the catheter. Once this catheter is in, you withdraw, you take your syringe, you have a saline flush, you take your syringe and you withdraw all 3 lumens all the way back to where blood enters your syringe, and then you flush. This prevents you from having air come in. Now, there are certainly other techniques to putting in a central line. This is a technique that's commonly used. It's a Seldinger technique where you have a catheter over the guide wire. There's going to be some deviations. Sometimes your kit dictates what deviations are occurring, because you may not have specific items in your kit that allow you to do some of the things that we were able to do here.